Good evening, everybody. I think you all can hear me. Uditha, you can hear me?
Yes, I can hear you.
Yes, fine. Okay. So, good evening, everybody. Students, welcome to PeMSAA evening talk. We have been continuing for the last nearly 2 months now. Today, we got a very special person to deliver the lecture today. He is Dr. Uditha Bulugahapitiya. I am sure at least some of you have seen him on the TV and the newspapers, and he's a very good communicator, and he brings a wealth of knowledge and experience with him today. And you might not know he's the consultant endocrinologist at National Hospital Colombo, and he's one of the senior most endocrinologists in the country at the moment. And when I invited him for the lecture today, he's ever willingly agreed, and you can see how attached they are to the alumni, the medical school, and it's a good example for all of you when you pass out. Help your junior colleagues, and that's how we can maintain our standards. So thank you, Uditha, for accepting our invitation, and he will be delivering a talk today on diabetes with case-based discussion. Okay, over to you, Uditha.
Right. Good evening to all of you from Colombo. And let me first thank the president of PeMSAA, Professor Kudagamana, who is my batchmate, who invited me to be part of this symposium today. Hope you all can hear me, right? And I hope that you can see my slides as well. So probably I have been given, I think, 2 hours, but I felt that I should probably have a talk for about 45 minutes, and then I think it is going to be more effective rather than going on to a 2-hour talk. And here what I'm going to do is that trying to see in a different outlook in management of diabetes. But I know as finally medical students and other medical students, they all have done their lectures, and their clinical experience probably in diabetes is quite good. But I know that majority of you in the final years, as a main case in the long case, probably will get something with diabetes. So mainly on diabetes, because you see them more commonly. And I'm sure that you get sometimes you can get one long question or some MCQs from diabetes. So I thought that I will probably not talk to you about medications and minor aspects of diabetes, but I thought that I'll discuss with you something in large, how you manage a patient in a long case, or some other important facts in diabetes. Therefore, ladies and gentlemen, what I'm going to do in my lecture with 2 case scenarios, that just to show you what's diabetes is, and then what are the risk factors of diabetes in my talk, and then how to diagnose diabetes. I'm sure that you all know, but with a case we'll see how you all will know that. And then the management of diabetes in a bigger way, not that in a always drugs and things like that, but I thought how you should look at in a management in a long case kind of a thing, and then how to manage diabetes. And I thought that's quite an important thing is myths about diabetes, because loads of even a long question can be on myths in diabetes and how you deal with it. And also because we are having COVID-19 epidemic, I think it's important that just one slide on COVID-19 and diabetes. So ladies and gentlemen, all of you know what is diabetes, but all of you know that diabetes is just a minute. Diabetes is a abnormal carbohydrate metabolism causing hypoglycemia, and it's a relative or absolute deficiency of insulin. Sometimes you will, with the time, you will understand there are so many mechanisms of getting diabetes, but for this particular discussion, we know that there is some peripheral resistance for insulin that the body creates. Therefore, with time, because of peripheral resistance, with time there is insulin deficiency. When the insulin deficiency is around 50% of the total requirement, usually you get type 2 diabetes. And type 1 diabetes is something, is a completely insulin deficiency, complete absence of insulin. And therefore, these two conditions are different. But although you know that type 2 diabetes is, in one way, it's insulin resistance, in the other way, it's insulin, relative insulin deficiency. But with time, you'll understand that there are many pathogenic mechanisms in causing type 2 diabetes. And if you, just a minute. Just a second. Yeah. So with that, why diabetes is important for us? We know that there's, diabetes is a epidemic in the world over. And if you look at the Asian countries, it's affecting the worst in the Asian countries. If you look at, and if you look at last 20 years, the biggest increase seen in the Asian countries. And Sri Lanka, we probably have about 1.5 million adults having diabetes. And we know that diabetes is not only a disease, it causes loads of other disorders, like the majority of the patients with diabetes myocardial infarction or a stroke, they will end up with a renal failure, blindness and amputations. Therefore, what will happen, that there's a huge health expenditure that the Ministry of Health has to spend on managing these complications of diabetes. Therefore, ladies and gentlemen, if you identify diabetes early and control properly, when you become doctors, I'm sure that you can reduce these complications. Therefore, the health cost, or I think it's important in health economics, because unless we have to spend loads of money in transplants and in bypass surgeries and stenting and so on. Therefore, know how to manage diabetes at this level is important, because it's quite a common condition, and you and I see so many patients in a ward at a time. Just to show you the global situation, like the world numbers, like 2015, it was 415 million at diabetes. Now probably we are thinking of 642 million in 2040. So there's a huge increase in numbers in world over in next 20 years. And if you look at the increase, is worst probably in the Asian countries, that almost doubling of numbers will happen in the Asian countries when you compare with the other countries of the world. Therefore, ladies and gentlemen, that you need to understand that you and I will see many patients with diabetes in future, not only the adults patients, but patients, young patients, children, school children, and patients, the pregnant mothers having diabetes, or young girls having diabetes going through pregnancy is a quite, it's quite common even now, but you will see more and more with time to come. Therefore, I think it's important that we know about this disease. When you look at the numbers, if you look at the research is not, there are no recent large-scale studies to look at the prevalence of diabetes, but if you look at the last few studies done in 2006, 2010, 2012, it's probably 1 in 10 having diabetes. When you take a whole country, probably 10% having diabetes. Therefore, 1 in 10 having diabetes is a quite a understanding thing. But when you look at a recent study which happened about in the Colombo urban area, showed that diabetes is quite common, and in 1 in 4 having diabetes, mainly in urban areas in Colombo. So we probably think that when you come into the urban areas of Sri Lanka, you will probably see 1 in 4 in diabetes. So it's quite a huge number, and with urbanization, we see more and more having diabetes. So therefore, in Colombo urban areas, we have seen 1 in 4 having diabetes when you compare the whole country probably having 1 in 10 having diabetes. All of you know what is type 1 diabetes and type 2 diabetes, but in this country, you know that the majority of we see type 2 diabetes 90%, but we quite 10% of diabetes in type 1 we see quite commonly in our clinics, because these type 1 diabetes are quite difficult to manage and therefore send into diabetes and endocrine clinics in our centers. But I think if you can think of managing type 2 diabetes at a larger scale, how do you approach a patient? I think that's what I think it's important. Other important thing for all of you to understand is that, if you look at diabetes complications, the majority of the patients will die when you have diabetes, die with a heart attack. So 65% of the deaths are due to cardiovascular disease in patients who are getting diabetes. So majority of the patients get a heart attack when you have diabetes. Then the second commonest cause of death when diabetic patients are the strokes. So 2 to 4-fold increased strokes in patients who are having diabetes. And therefore, heart disease and strokes are like 2 to 4-fold increased in patients who are having diabetes when you compare with the patients who are not having diabetes. And therefore, ladies and gentlemen, you need to understand, when you see a diabetic patient, your objective should be prevent the heart attack or a stroke in future, because that causes the mortality of these patients. Therefore, you and I are not only managing blood sugars in these patients, but you are probably managing beyond that, managing heart disease, managing neurological condition which to prevent a stroke in these patients. Just to show you, ladies and gentlemen, just to show you that mortality in people with diabetes, the commonest is the ischemic heart disease, and when you compare, the strokes are the next common thing. So but that has to be understand to think about the health economics, because it's a huge cost for the Ministry of Health, as well as that you need to understand that your objective in managing diabetes is to prevent a heart attack or a stroke, because those are the two common causes of death in diabetes. Before I go into one or two few cases, very simple ones, but we know that the type 1 and type 2, type 1 diabetes, the absolute deficiency of insulin. Therefore, they have a very short history when they present to a ward with sometimes the ketoacidosis or abdominal pain. They have loss of weight and appetite, increased appetite for a short period of time when they present with type 1 diabetes. Type 2 diabetes, in the other way, is a long history. But I think as a young doctor, you should be able to differentiate type 1 and type 2 diabetes in the history itself. How do you differentiate type 1 and type 2 is important thing. Usually, type 2 diabetes has a family history. If the patient's mother, father, brother, sister has got diabetes, and high chance that you are looking at a patient with type 2 diabetes. That's an important point to understand. So if the patient doesn't have any history of mother, father, brother, sister, or the first degree relative having diabetes, then you have to think about whether you are dealing with the type 1 diabetes. So that history is so important. And then if the patient is like obese or the overweight, you are dealing with a type 2 diabetes more likely. And if you are dealing with a patient who has got lean body, then you are dealing with a patient with type 1 diabetes most probably. And then I think if you see on examination, if you see the patient has got features of insulin resistance, I'll show you later one of the photographs. If you see some features of insulin resistance, like darkening of the neck or the armpits, then those are called acanthosis. And if you see that, you are dealing with a patient with type 2 diabetes. And therefore, there are few. So one is that if the patient is obese, second is a family history, first degree having diabetes, and then the patient with a with a history of insulin resistance. And then if the presentation is long, like having symptoms for months and months and months, then probably you are dealing with type 2 diabetes. Type 1 diabetes, because of the absolute deficiency of insulin, they present a very, very, very short. Sorry, I think hope you can hear me now. So there are some other types of diabetes as well, and that gestational diabetes, where you would get diabetes during pregnancy. I think it is beyond your type. Then some drug-induced kind of diabetes, and there are some other types as well. But I just want to show you, in a history, if you get a long case, you need to probably tell that this is type 1 diabetes or type 2 diabetes on the basis of the history itself, not going into any investigations. So type 1 diabetes is diagnosed when the pancreas stops making completely insulin. There's no insulin. That's why they come with the ketoacidosis. The ketone body formation starts when there is no insulin. But if there is insulin, the ketone body formation is stopped. That's why type 2 diabetes doesn't present like that. But type 2 diabetes is a condition where you have relative insulin deficiency, as well as insulin resistance. And therefore, you need to understand there are two different pathogenic pathways for type 1 and type 2 diabetes. With that short history, ladies and gentlemen, I would like to take you through a very simple two cases, because at your level, I don't expect you to know too much about diabetes. But when I go for the final year exams, if a student is not up to this level, I am not happy to pass that person for the final year exam. Just one case, 50-year-old banker is coming to see you with a fasting blood sugar of 140 milligrams per deciliter. And he just wants to know whether he has got diabetes. So this is a matter of diagnosing of diabetes. So 140 milligrams of deciliter. So ladies and gentlemen, when you get a patient in a ward base, or a new patient, or on an exam, or whatever the situation, it's important that you look for symptoms of diabetes. So all of you know the symptoms of diabetes, like increased thirst, weight loss. If somebody has got weight loss and increased appetite, there are only two differential diagnoses. One is diabetes, other one is thyrotoxicosis. So cancers and other things, you lose weight, but they lost appetite. So I think important that you realize. So if the patient has got increased appetite, losing weight, then go to the toilet, frequency of urination is increased, extensive thirst, then extensive hunger, then you know that these are common symptoms of diabetes that you get. And there are some rare symptoms of diabetes that you and I come across. There, the blurring of vision. If somebody comes and tells you that I suddenly got my last few days I'm having blurring of vision, that is one thing that you need to understand, that this guy has got diabetes. And if somebody comes and say that scratching of external genitalia, then that is something that you need to be careful about, and go ahead and do some blood sugars. And extreme tiredness, unable to get on with the day-to-day work, is also something important, which is not very common, but you need to understand. So if somebody comes and show you a report of 140 milligrams per deciliter, important that you look at whether the patient has got symptoms of diabetes. Sometimes you need to understand that there is a 40% of the patients with diabetes have no symptoms. That is the most important in an MCQ pattern or a clinical basis that you need to understand. Not all the patients with diabetes have symptoms, 40% of patients will have no symptoms of diabetes. Therefore, they may not identify by symptoms. Therefore, only the 60% will have some symptoms of diabetes that you need to understand. So after inquiring now, what I told you that I look at the patients with the patient's symptoms and signs, then you look at the patient. Now these are, you have seen these commonly in our setting. These are the acanthosis in the neck and the armpit. If you see this, with that blood sugars, you know that the patient has got diabetes without anything. And if you see, you need not to differentiate it type 1 or type 2. When you see the insulin resistance like these features, this is nothing else, it's type 2 diabetes. And also the central obesity, which I have shown here, is one common thing that you will find in type 2 diabetes. So ladies and gentlemen, when you see a report or when a patient, when you come across the patient, it's important that you look for symptoms and you look for examining for the insulin resistance features, then you know the patient has got diabetes. So what are the diagnostic criteria for diabetes? Because with that history with 140, we know that if the fasting blood sugar is more than 126 milligrams per deciliter or HbA1c of more than 6.5 or 2-hour OGTT or any time if the blood sugar is more than 200 milligrams per deciliter, that patient has got diabetes. So in this criteria, our patient is having 140 milligrams per deciliter, so he has probably got diabetes, whether he has symptoms or not. But usually the guideline says that if the patient doesn't have symptoms, you might have do another test. You can do HbA1c, or you can repeat do a random blood sugar and see whether you are meeting the criteria. But if the patient is symptomatic, one reading is enough for you to diagnose this patient. But if the patient is not symptomatic, even the blood sugars like 300, 400, then you need not to do a second test because it's beyond your cutoff a lot. Then you diagnosed without a second testing. So I think I want you to understand how you get on with this diagnostic criteria, because if it is closer to the target, probably symptoms are extremely important. If not, you go ahead and do another testing. And if the patient doesn't have symptoms, always better to have a second test. But if the cutoff is if the blood sugar levels are very high, then probably you need not to do. So according to this fasting blood sugar, we know that patient has got diabetes. Now this 200 cutoff, you usually take 2 hours after a major meal or a OGTT, but that is because that is the time that you get highest blood sugars in your blood. But when you check blood sugars at any time of the day, if it is more than 200, that means that patient has got diabetes. So ladies and gentlemen, how do you manage this patient who has got fasting blood sugars 140 and he has got diabetes, first newly diagnosed type 2 diabetes? So there are two types of management. The most important thing in your long cases or whatever the exam base is, talk about in a common way, that lifestyle modification is very, very important, and then you have a pharmacological management separately. What is lifestyle modification? It's a patient-centered care. You need to use this term, which is a patient-centered care. It is not the doctor-centered care, but it's a patient-centered care. You need to understand what is the patient's can do about it, and what kind of a diet patient is he taking, and what kind of exercise the patient is taking. And then you need to decide and come in terms with the patient. You have to give a patient-centered a diet and exercise way of doing it, because unless, what will happen, you decide what to do, which the patient is unable to do. So when you look at the diet, this is one of the best diet that the diabetic patient can be on. You need to understand that patients with diabetes can eat anything, but the more important, the portion size. So basically, the half vegetables in the plate, and a quarter can be rice, quarter can be meat, fish and eggs, and therefore patient can have a different vegetables, different proteins and different kind of rice when you have a plate method. So plate method is the way forward in type 2 diabetes, and patient has to understand also how you wherever you go you can have it. Even now when we talk about diet, people think that there's something called diabetic diet. There's nothing called diabetic diet. And if you have got somebody else in the family who has got diabetes, I don't think that you should have anything special for that person. What you want is get the plate and serve into your plate the way that we are thinking that the best way. And try to ask what kind of exercise is important for the patient and give a patient-centered exercise program for the patient. So when you, because a few things about diet, because I've thought that when you get a long case, you should be able to, talk about a bit on diet. We need to get the patient to 3 main meals and 2 snacks in between. That is the way forward in a diabetic patient. But you need to understand diabetic patients can eat very well because they are having 5 meals a day, 3 main meals, 2 snacks, and they need to suffer too much. They should not understand that when they get diabetes, they are unable to eat and so on, because that's a bad thing. Therefore, you need to get them to freely understand that they are they can have a usually almost normal diet. So again, I'm showing you the diet I have shown you here. This is what we are looking at. Different vegetables in this half, and this protein, and this is carbs, and different things you can have it. So when you have carbs, certain people ask whether we can eat these kind of carbs. Yes, the patient can decide what kind of a carbs. So the important point is, if you're having something like kos or dil or something like that, this is a part of the carb. So it should go from the 1/4 of the rice portion. Therefore, all of these are commonly using carbs in our country, but we need not to tell the patient that you should only eat rice. No, there is nothing like that. So whatever the carb is okay, but if you are eating these kind of carbs, it should be that part of the 1/4 of the rice portion in your plate. So they can easily have anything they like to eat. Proteins can be variable. The milk, the egg protein is extremely good. You should never say don't eat eggs in these patients. They can even 2-3 eggs a day is extremely good, because 1 egg will give 5 grams of protein, which is extremely good. And milk is good. If it is natural milk, is further better. Any meat or fish is better, but less oily stuff are better. But there is no need of too much of selection in the meat and fish, because everything is going to be much better. So these are the pulses that I'm showing you. All of you know the most of the pulses like paripu and kadala, mungata, and all these have about 50% protein, 50% carbs. So it's quite good, but we know that when you are eating a portion, the 50% is carb from that as well. So we need to, if you are eating, you must know that this also should have part of the carbs that you are eating. 50% is carb, 50% is protein, whatever these things are using. So green vegetables, you can have anything. I don't think that we should tell our patients to select vegetables, because all the green vegetables, even carrot, beetroot, and tomato and everything is quite good. We have very low sugars in our vegetables. So therefore, we can also get them to use any of these vegetables according to their wish when they eat their meals. And fruits, we have so many fruits in our country. So we can get them to use fruits as a snack in between 2 snacks. So when the fruit is more sweet, the glucose content is too much. Therefore, you have to reduce eating. So whenever you eat something, if it is sweet, that means more glucose, less sucrose. And therefore, if you look at things like mangoes, it's very, very sweet. Mangoes have higher glucose content when you compare about the fructose content. So you can just make it out when you eat. If you eat things like this, it's usually very sweet and watery, very high sugar then, very high level of sugar. So whenever it becomes watery, the higher sugar. When it becomes sweet, then it's more sugar, whatever you eat. But still, people can eat twice a day fruits. Usually what you and I do is the same, therefore no problem. But when you go into details about vegetables, you can think about some vegetables, some more having more carbs, but you need not to worry about too much about this because those are minor things. But if you have a portion size, I think that's going to be a good meal. Snacks, variable snacks, 10 o'clock in the morning, 3 o'clock in the evening. I think if you can talk about in your long case, what kind of meal plan you give to the patient, what kind of an exercise program, that's going to be quite good. And what patients should avoid is a high calorie stuff. So all of these stuff are very, very high calorie. For an instance, if you eat this kind of a chocolate cake, this will have about 450 calories. So 450 calories means about 4 to 5 hours exercises. So to get this one out of your body, so it's huge. If you look at a Big Mac meal at McDonald's, about 650 to 750 calories. Again, 6 hours exercises. So it's so difficult if you eat some high calorie stuff. It's therefore try and avoid these things. Children and adults can consume when you have diabetes, but on and off when they go out, you can use it, and not at home. Not get the deliveries to deliver the stuff to home or something like that. And also to avoid the sweet drinks is very, very important because they're very high sugar, all these sweet drinks. I'll show you one photograph of this. So tips to promote healthy diet is give a portion size, that is one thing, and give them a variable fruits and variable vegetables to use, variable pulses to use. Then you have a huge selection to try and say that high calorie, limited use of high calorie stuff, and also home gardening and all that if possible. That's going to be also an interesting thing which family will also be involved. So portion size and is the more important thing. And when you think about drinks, I think you know that the traffic light coding system, try and go for the green ones whenever you go to the supermarkets and so on. So you tell your patients. So in the long cases and all that, the drinks always try to go for the low calorie stuff, which is the green label ones. So that's what I want you to give for a dietary prescription, which can be accepted by everybody, which is easy to practice, and patients will accept more. What about exercise? What you usually need is about 30 minutes exercise, which is aerobic, at least 5 times a day. So that's quite an easy thing. 5 times daily aerobic exercise, walking, jogging, running, swimming, cycling, anything the patient can be, or working in the gardening or playing a game or something. It's quite a good thing. So 30 minutes minimum, at least 5 times weekly. So you need to recognize what the patient can do and then promote that to the patient is the best thing. And the important thing is that also there are kind of exercises that you can do while you are at work. So work-related exercises need to be enhanced in these patients, especially get your things done on yourself, to walk in the corridors, to try and use steps. Those are work-related exercises, which is very, very important. And even if you can ask the patients to, when they are seated and working, just get up and go around the table and just sit. That is also an important exercise. So I think exercises are different, and you have to find time to do the exercise. So when you do exercise, usually what it improves the insulin resistance. Therefore, when the blood sugars will automatically come down because there's insulin resistance improves, and there's insulin secretion improves, and there's a weight reduction happens. The insulin requirement goes down, and therefore the huge importance on exercise and also the correct diet. So tips to improve the physical activity: try and avoid escalators and in other areas, and try to go to a short distance places walking, and always try to exercise using the family together, and not to have drinks or any meals in front of the any TVs and all that, because then you don't know what kind of portion that you are eating, because the eating can be huge. Therefore, try and improve these things. These things should be avoided in the patients with diabetes. Just to show you, my dear, this is very, very important slide that I'm showing you. If you are drinking, when you are tired, if you drink a small, the Coca-Cola, this kind of Coca-Cola, it contains 9 teaspoons of sugars. All of these contains 9 to 10 teaspoons of sugar. So if somebody having a swim for about 1 hour, come back and drinking this Coca-Cola, the almost your exercise and the calorie expenditure is becoming almost zero by drinking this kind of drinks. Therefore, you have to be careful when you drink so much of sugar. So one thing of managing diabetes, the kind of a case that I have put forward for you is the dietary plan and exercise which is acceptable to the patient. Then you come to the pharmacology, which you have learned different drugs in pharmacology and also the final year. But I'm not going to tell what drugs that you should use, but just to show you in a way that you should tackle in a long case. And it's always a multidisciplinary team approach in diabetes, because not only a physician, not only endocrinologist, there's a dietitian or a nutritionist involved. Then the exercise, exercise. We can get somebody also involved in the exercise. Therefore, it's a multidisciplinary teamwork is important managing type 2 diabetes. One is pharmacological management. I have already talked about non-pharmacological management, which is patient-centered diet and exercise program, which is, I think those are terms are important in the modern medical practice. With the pharmacological management in type 2 diabetes, why you consider pharmacological management? To achieve the glycemic target. So you have to achieve a certain glycemic target, and then we have to screen and treat microvascular and the macrovascular complications of these patients. That's a large way of discussing the management of type 2 diabetes instead of going into the drugs in a minor way. So then we know that if we look at the drugs that is available, all of you know about metformin, all of your ward patients on sulfonylureas, pioglitazones, sitagliptins, GLP-1 analogs are not commonly used, but we are commonly used in our setting, and SGLT2 inhibitors have come to practice. So those are very cheap at the moment. So these are the drugs that are available for you. At least you should know, at least these drugs are available for you to use, and how to use is and also insulin is available. Then most of the patients may need a statin or a aspirin and statins in order to manage these patients properly. So how to select these different medications? First is the efficacy, how efficacious these medications are. So I think you can talk about in the case. Then we are happy to add some tablets which are cardiovascular benefits, like metformin, SGLT2 inhibitors are some of the examples for cardiovascular protective or benefits. Then effects on weight, if the patient is on a weight neutral drugs or weight reducing drugs, those are better, like metformin, sitagliptin, SGLT2 inhibitors are quite good in that manner. And then the side effect profile, the probably hypoglycemia and the weight gains are the ones that we don't want. Those are basically caused by drugs like sulfonylurea. So if you can remember these facts, I think when you selecting medications, you can always discuss with the examiner or discuss with the patient. These are the ways that I'm trying to select medications for you, not only to reduce your blood sugars, but also to improve your heart, protect your kidney, as well as reduce your side effects and maintain your weights and so on. So I think it's important that you keep these things in mind in not going to the micro level of the management, but it's a larger way of looking at how a patient should be managed. So first is dietary and patient-centered diet and exercise program. Then you look at the multidisciplinary team approach to manage diabetes. In that, you select medications in one way, and other ways how you select individual medications by looking at these benefits. So when you look at a medication, you look at glycemic control, the blood sugar control in one hand. Other hand, you have to balance the hypoglycemia, then the then the protection of the heart, protection of the kidney, weight gain, and so on. So it's a balance between your blood sugar control versus other aspects in terms of blood sugar. So I think it's important that you need to understand. So all the guidelines in managing diabetes, I hope that you know all these medications, but first option is metformin, second option is any of other medications that you know, can be insulin to any of the medications. The first is metformin still, but when you come to when you read about diabetes, you may understand that metformin, there are some other options with the metformin as well now, but for your level, I think first you start metformin, then you start sulfonylureas, pioglitazone, sitagliptin, SGLT2 inhibitors, so any of these medications. So I think it's important that you look at least you say that the first is metformin, and then one of the other medications that you look at. So when you start diet and exercise in one hand, patient-centered diet and exercise program, other hand you select the pharmacological management, the way I told you, then you look at the glycemic target. For a majority of the patients, HbA1c should be less than 7. HbA1c should be less than 7. So pre-prandial blood sugars should be, or fasting blood sugar should be less than 130. Post-prandial blood sugar should be less than 80. Those are the glycemic targets in patients with diabetes. So you try to achieve this. So I think that's what you need to discuss in a case. So that's how we have seen majority of the patients less than 7 or 6.5. You can consider at 7. That's a better thing for you all. And then some of the patients we can reduce to 6.5. The patient can afford to reduce to 6 or 6.5 without hypoglycemia. We can still do that. Then, ladies and gentlemen, the next is blood pressure target. So one is a glycemic target you need to tell about, the blood pressure target, which should be less than 140/90. If it's more than 140/90, you always start a medication, which can be either ACE inhibitor or ARB blocker is probably the best. So think about these two targets and then think about aspirin. Usually, if the patient is more than 50 years with a one cardiovascular risk factor, smoking, hypertension, microalbuminemia, or cholesterol, so add aspirin. So such a simple, majority of the patients more than 50 years may need aspirin in this, according to this. So ladies and gentlemen, that I took you through a patient who has got type 2 diabetes, newly type 2 diabetes, is how to diagnose. Then I went through some symptoms. Then I told you that there are many patients may not have symptoms, and then I got through how to manage in a multidisciplinary team approach. Another case, we'll take the same patient, a 50-year-old banker coming with fasting blood sugar of 110. So he wants to know whether he has got diabetes now. So it's 110. What do you think about that? So this patient has got what do you call pre-diabetes. What is pre-diabetes? If your fasting blood sugar is between 100 to 125, so our patient is having 110. So 100 to 125 milligrams of deciliter, he has got pre-diabetes. Or your postprandial blood sugar of 140 to 200. Or your HbA1c 5.7 to 6.4. So you are having pre-diabetes. So when a patient has got blood sugars of pre-diabetes, always do another test, HbA1c, because some of the patients who are having fasting blood sugar within pre-diabetes range may have diabetes in other two investigations. So you look at the other two investigations as well. So probably this patient has got, so majority of the patients have got pre-diabetes, some of them have got diabetes here. So how should we screen patients for diabetes then? Because we know that the 40% of the patients are having no symptoms, and pre-diabetes also, there's a condition called pre-diabetes. Therefore, the important thing to understand is that if you're an obese patient, your BMI is more than 25 or 23, and if you're Asian, and if you're having additional risk factors like physical inactivity, obesity, hypertension, dyslipidemia, or if you have insulin resistance, then you need to screen for diabetes. So I think you need to remember these things, at least to discuss in a long case, or if there's an MCQ, or if there is the long question, then you can always discuss these things. If your BMI is more than 25 or 23, and if you're Asian, you need some. If you're having another risk factor, you need to go ahead and look for. If you're more than 35 to 45 years of age, then also it's an indication to look for blood sugars. So when I go back to pre-diabetes, you know the cutoffs now, and why you want to diagnose pre-diabetes. When you have pre-diabetes, for this patient, that I should tell the patient, you are having very high risk of getting diabetes in future. About 50% in next 2 to 5 years time it turn into diabetes. So if you have pre-diabetes, you are going to get diabetes in near future. So it's important that you understand that at the same time you are having a high risk of getting macrovascular complications when you have pre-diabetes. So that means the patient who is having pre-diabetes has high chance of getting a heart attack and a stroke than a normal patient. So that's why pre-diabetes is so important, and so the management of pre-diabetes is so important. Identification of pre-diabetes is so important because we know these are the patients who are going to get diabetes in future. Right, how do you manage them? Majority of the patients with pre-diabetes manage with lifestyle modification. If you have very high risk, yes, you can think about pharmacological management, but majority of the patients, diet, exercise, weight management, and pressure management, and things like that. So I think what I want to introduce here is the new term of pre-diabetes, or a better term for pre-diabetes, patients who are having risk of diabetes. The pre-diabetes, the same term is, better term is patients who are having risk of getting diabetes. Therefore, there's something called diabetes and there's something called pre-diabetes. And so the second case that I wanted to show you the importance of pre-diabetes to understand. Why diabetes is important? We know it causes majority of the microvascular and macrovascular complications. I told you about cardiovascular disease. I told you about strokes. And we know that the leading cause of blindness in this country and the world over is the diabetes, diabetic nephropathy, we know, diabetic neuropathy, we all know all these things. So diabetes is not just a blood sugar, it's a multi-system disease. It's affecting majority of the systems in the body, causing disabling disease. Therefore, it's important to understand. So if you look at the heart disease in diabetes, usually, you need to understand it is usually happening in younger age groups. When you have diabetes, you are highly likely to get a heart disease in a young age group. And also if you get a heart disease, it's going to be more severe and you can get more complications with that disease when you have diabetes, and you have a high chance of dying from the heart attack when you have diabetes. So those are the 4 things that you need to understand. And majority of the times, these myocardial infarctions or heart disease can be asymptomatic or painless in diabetic patients. So they can be painless, they can happen in early ages, more severe disease, more complications, more death can happen when you have patients with diabetes, hypertension. So I think that's one of the most common cases. So I have shown you this, the majority of the patients with diabetes either die from a heart attack or a stroke. So when I look at the stroke, again, it is about 2 to 4-fold increased chance of getting a stroke in patients with type 2 diabetes. When they get a stroke, they get a stroke in a young age, and they get a severe strokes, more complications, even death can happen in more when the patients are having type 2 diabetic patients having stroke when you compare to normal. I think it's important that all these features. When you look at the diabetic kidney disease, the more important point for you to remember is that the commonest cause of kidney disease or the renal failure world over is due to diabetes. So the commonest cause is diabetes. So I think I'm not going to detail about diabetics and diabetic nephropathy. I'm sure that you may have some nephrologists talking about kidney disease, and they will talk about diabetes kidney disease for sure. Then the important thing is retinopathy. These are the changes of the retinal changes that occur in diabetes, which causes blindness. You get small bleeding spots in your retina, and finally you get the blindness of this disease. The common two types of, at least you should know as a finally medical student, the pre-proliferative diabetic retinopathy and a proliferative diabetic retinopathy. Because if the patient has a pre-proliferative diabetic retinopathy, you need not to worry about the bleeding and so on. But you have proliferative retinopathy, this patient needs treatment in a specialized center. That's why we are trying to differentiate proliferative diabetic retinopathy from pre-proliferative diabetic retinopathy. So at least when you look at the fundus, you should be able to say this is a proliferative diabetic retinopathy. You can see that there are some bleeding spots and there are some proliferation. So it's a proliferative diabetic retinopathy that is important. So these are the different kinds of things that I have shown you. So when you have diabetic eye disease, more important thing to understand it, usually diabetic eye disease having no symptoms, usually they can get sudden blindness with diabetes. Therefore, you should not ask how is the vision and all that, because they can develop a blindness with a good vision. And the more important to remember is that the commonest cause of blindness in the working age group world over is diabetes. So that's the more important point. The working age group, the commonest cause of blindness is diabetes. So that's that you think that how serious is that problem. Therefore, annual eye checking is so important in these patients. And I'm not going to talk to you separately about diabetic foot disease, because I'm sure I saw that there's a vascular surgeon who has talked about something. I'm sure that vascular surgeon will talk about this callus causing diabetic foot ulcers and ending up with amputation. And diabetic foot disease is worse than a cancer. If you see a patient, we see a patient who has got amputated of a limb, that patient's life expectancy is less than 5 years, because you are seeing in a part, it's a generalized disease that you only see in the leg. It's a generalized disease, and they will die less than 5 years of life expectancy. So it's worse than a breast cancer, worse than a prostate, even worse than a lung cancer now. When you have a foot disease, that you know their life expectancy is very, very low. So how do you prevent these complications? I talk about diabetes macrovascular and microvascular complications. I told you the importance of these complications, and very important few points about all these complications. The prevention of complication is, first thing is good glycemic control, good blood pressure control, then good cholesterol control, and then good dietary adherence and exercise and stop smoking. So those are the 5 things that you need to discuss in a long case, that if you want to prevent complications, these are things that I should do in a patient who has got diabetes. And also, because of these complications are common, you need to review these patients every year to look at all these complications and do some investigations in terms of that. So that's the plan of a diabetic patient or a pre-diabetic patient, and how to look at the complications and so on. So that's what I thought of looking at the pre-diabetes, how to manage the complications, and what are the important points of complication. I didn't go into detail about it because I know that you will have gone into detail of the lectures, and also how to prevent in a very small sentence, how you should prevent in 1 minute. How do you tell how you prevent complication? Ladies and gentlemen, I just go into a different topic. I thought that is important in an essay question or a discussion point of view, that myths in diabetes, and loads of myths in diabetes. But I thought I will just discuss few things about it, and then you can work out of this. Can diabetes be asymptomatic? I have already told you 40% of the patients with diabetes are not having any symptoms, therefore they can present without any problem. So diabetes can be asymptomatic. Can diabetes be diagnosed by urine sugar? Answer is no. I hope that your units are not doing urine sugars now, because I can remember when I was a medical student at Peradina, we used to check all the urine sugars, but I think the urine sugar era has gone, because diabetes cannot be diagnosed by urine sugar. It's essential that you do a 8 to 10 hours fasting blood sugar, and patients can take any amount of water when they are fasting, or then you can do HbA1c or a postprandial blood sugar in terms of diagnosis of diabetes. So urine sugar is not at all a useful thing to do. Can diabetes be controlled only by diet and exercise? Yes, sometimes if the patient is willing to do a good dietary adherence and a good exercise program and weight maintenance, yes, some patients can manage diabetes without any tablets, but majority of the patients will end up in tablets with time to come. That's an important point to say. If you are adherent to a good diet, an exercise program and weight management, and then you may go on without any tablets, but majority of the patients will end up with tablets with time to come. I think that is the one myth that people are having. Once the sugar is controlled, can a patient continue the same medication? So that's how some people think. When you come to a clinic when the blood sugars are controlled, you just continue the same medication. Answer is no, because diabetes is a chronic disease, and diabetes is a chronic progressive disease. I think those are the two terms that you need to understand. Diabetes is a chronic disease, diabetes is a chronic progressive disease. Therefore, with time, diabetes gets worsened, your blood sugars goes up, insulin secretion goes down, and we need to increase the drug doses, add on new medications, add on insulin at the later stage of the disease. Therefore, patient needs to be followed up every 3 to 6 months in terms of upgrading the medications, changing the doses, because it's a chronic progressive disease. I hope you understood. Once the blood sugar is controlled, can the treatment be stopped? Yes, answer is again not, because it's a chronic progressive disease, and patient need long-term, lifelong treatment, diet and exercise, everything together. Therefore, it is a disease that you need to get on with time and go on with medications and so on, not to stop it, but it's a long-term medication. Can diabetic medications cause kidney disease? I think it's a huge myth, and we have seen few times the newspaper articles, radio programs. People are talking about diabetes medications can damage the kidney. Especially people are talking about metformin can kidney damage. Sometimes you have seen doctors saying, yes, your kidneys are damaged because of metformin. Metformin has no evidence whatsoever to damage the kidney. Metformin can protect the kidney to a great extent, and one of the best medications to protect kidneys. So therefore, diabetes causes kidney disease. Metformin never causes kidney. Even when the kidneys are damaged, at even that point, the metformin cannot deteriorate the kidney disease. But only thing is, it can give rise to lactic acidosis. That's the reason that we stop metformin. Therefore, ladies and gentlemen, metformin doesn't cause or doesn't progress the kidney disease. And sometimes people think insulin can damage the kidneys. There's not a single medication we used in management of diabetes will cause kidney disease. Therefore, please make sure that you discuss these things with your patients when you talk about. Is the insulin last resort? Some patients ask, doctor, my diabetes had got worsened and now I am on insulin. No, there's nothing called it's a last resort. It's a one stage of the disease. You initially get diabetes, then you get diet and exercise, sometimes with or without medications. Then this disease will progress with time, and the beta cells functions will go down, and therefore insulin secretion goes down. At some point, the patient needs some insulin, and it doesn't mean that you have a severe disease or it's just the last resort. There's nothing that we can do. No? Insulin can control diabetes very well. And insulin is energy. Patients will feel much better when the patients are on insulin because it's energy. Even if you look at the Olympics and all that, majority of the patients who have misused insulin to gain the power and energy. Therefore, insulin is a good medication. It's an injectable, but it's a very, very simple way of injecting by using a pen now, even less than a mosquito bite at the moment. So, ladies and gentlemen, insulin is very safe medication, doesn't cause any problems, and also it's not the last resort. It's a good option whenever the patient's blood sugars are not controlled in the tablets. Can good blood sugar prevent complications? Answer is yes, to a greater extent, when the blood sugar control is good, when the blood pressure control is good. Not only the blood sugar, that's the important point here. Not only the blood sugar, when the blood sugar control is good, when the blood pressure is on target, when the cholesterol is in target, when you do exercise, then you stop smoking, moderate alcohol or no alcohol, and do exercise, weight management, then you prevent complications. So delay the complications. But only the blood sugar may not do that. But if it is a multidisciplinary teamwork, a multifaceted approach to diabetes can prevent complications by looking at these various areas in diabetes. Next myth is, can diabetes be controlled by alternate medications? But I don't like to talk about it, but loads of Ayurveda medications and loads of other people are talk about diabetes. But we in our experience is that most of the other Ayurvedic doctors and all that are all taking diabetes for Western medication. So I feel that you have to encourage people to use Western medications. They are very safe. Highly, loads of studies have gone through, and safety of these medications have been confirmed. Therefore, I don't think the alternative medication is a good option at this point. So other point is that majority of the mothers and the ladies are worried. Diabetic mother with a normal pregnancy and a healthy child. Can a diabetic mother have a normal pregnancy and a healthy child? Yes, answer is here. If a girl has got diabetes or a mother has got diabetes, that doesn't mean that they will have an unhealthy pregnancy and an unhealthy child. They can have a healthier pregnancy. They can have a healthy child like any other person. But important thing is get the blood sugars controlled properly and adhere to the medications properly, diet, exercise adherence properly. Then you will have a normal pregnancy and a healthy child. There's no problem at all. Other problem is, diabetes can be cured. Majority of the people come and ask whether diabetes can be cured completely. And if you look at the latest articles, a lot of people are talking about diabetes cure, even in Western medicines. But yes, some kind of diabetes some patients with diabetes can be cured if the patient is newly diagnosed type 2 diabetes, and if you are happy to reduce about 5 to 10% of your weight, diet and exercise, good tolerance, probably diabetes can be reversed. Not probably cured and reversed. May for a shorter period, maybe 2 years, 3 years, but when your lifestyle getting affected, and then again you get diabetes. So it's not cured probably, but can be reversed to some extent, because we have seen that diabetes can be reversed or even cured with the bariatric surgeries that we do. And therefore we understand that point. And therefore, if somebody can reduce 5 to 10% of weight and newly diagnosed type 2 diabetes, then probably we can think about reversal of diabetes, but you may not be used to cure. Can diabetic patient have healthy, happy life? Answer is definitely yes. If you, I think sometimes some articles have shown diabetic patients are healthier than other people, because they, from the time of having diabetes, they're careful about their diet, they're careful about their weight, they're careful about the exercise, and everything together. They probably have a healthier life than others. Therefore, the diabetic patients probably can have a healthy life, happy family life, with the children, and there's no issue of pregnancy, and therefore you need to understand. Ladies and gentlemen, my last slide is about COVID-19 and diabetes. It's actually recently I gave a talk about COVID-19 and diabetes, but that's about half an hour talk. But for your level, I think what you should know is, when you have diabetes, when you are high risk of getting COVID-19 infection, if your blood sugars are poorly controlled and you are exposed to the disease. And then if you get COVID-19, you are having more symptomatic disease and more severe disease and more complications of the disease. And all the evidence have shown more ICU admissions when you have diabetes and increased mortality when you have diabetes. Those are the more important point that you need to remember, because we know we have identified the pathophysiology of this diabetes and COVID very well, because diabetic patients also have vascular inflammation, therefore their endothelium is not that healthy, and COVID-19 also affects this endothelium and causes coagulation issues and thrombosis. Therefore, these diabetic patients are more prone to get that. So I think COVID-19 and diabetes is something that we are all interested about. I'm sure that people will ask more and more questions of your MCQ papers, long answers, and also, but these are the things that you need to know in a nutshell about diabetes. Therefore, ladies and gentlemen, I think I covered most of the things. Diabetes is a chronic progressive disease. I think the prevention is the most important thing. Weight management, avoid unhealthy diet, and go into a healthy diet. I think where you stand is the more important thing. And if you have diabetes, how you look at your children is the other issue, because it is important that you prevent diabetes rather than getting diabetes, and try to overcome that. I think that's all that I want to talk to you. And let me thank PeMSAA and the President, Professor Kudagammana, for inviting me. And I didn't go on a way that usual pattern of a lecture, but I just wanted to touch a few things, and I just want to give you that overall management plan as well as certain important things in diabetes. Once again, thank you very much for PeMSAA for inviting me. Thank you.
Okay, Uditha, thank you very much. So students have posted some questions in the chat box.
Yes.
Would like to? Do you think you can answer some of them, or you would ask them? To unmute and ask them directly from you?
Yeah, that's fine. If I can hear, that's fine. Or if you can tell that, whatever is okay. I'm all right.
Yeah, there are some. Already there are some questions in the chat box. Uditha.
I can't see that. How can you go to that?
Okay, so one is, sir, do we have to try lifestyle modifications alone first time before starting pharmacological methods in a diagnosed diabetic patient?
Yeah, I think that's an important question. I think now the new method of managing diabetes is that you start lifestyle modifications, then medications together is the way forward, because if you start, when you get diabetes, what you need to do is try and aggressively treat diabetes. Earlier, what we did was, like 10 years before, what we did was, when you had diabetes, you asked them to be on a diet and exercise for about 3 to 4 months, and look at blood sugars. Then blood sugars are getting worse, and then you start metformin. Then you go ahead and start some other medication and so on. Now the method is quite different. Aggressive treatment from the beginning. So you start dietary advice at the same time, exercise at the same time, medication at the same time. So that is the best way, because the important thing in diabetes is first 5 years, most important in whole life of diabetes. If you manage diabetes properly for the first 5 years, aggressive treatment, you now it has been shown that you are getting less problems lifelong. Therefore, you should not just hang on the thing and just wait. And the best thing is right from the beginning, a multifaceted treatment.
Right. Thank you. And next question is, sir, regarding AC inhibitor use in proteinuria, when should we stop it if the patient progresses into further renal function deterioration? Is there a certain GFR or similar cutoff to make that decision?
No, actually, there are lots of new things have come with AC inhibitors and ARB blockers. I'm not going to complicate you with that. But for your level, I think when the patient has microalbumin disease, the microalbuminuria is not the term that you use now, but I'm sure that you are still using the same term. Therefore, I will use the same term. The microalbumin urea stage, you start either ACE inhibitor or ARB blocker. and then patient can go into retroalbuminuria, will continue the ACE inhibitor or ARB blocker. But ACE inhibitor, ARB blocker, you should not combine together. You should not combine together, either ACE inhibitor or ARB blocker. Then you add on, next is when the pressures are going up on the urine microalbumin is more, then you add on the other medications like calcium channel blocker. And beta blockers are coming lower in the range. Earlier, I know that the beta blockers are very high up in the, but now we offer very low. And then the patient can go into the next stage of the disease where the renal functions can get affected. And then still you can continue the ACE inhibitor or ARB blocker without any problem. But what happens is that at the end stage renal disease, if the potassium is going up, then the ACE inhibitor and ARB blocker, you have to come down with the dose, probably half the dose, not to stop the dose, because the potassium can go up in the end stage renal disease. At the same time, when the patient going into the end stage renal disease, because of the vascular problems in the afferent arteriole of the nephron, if you use the ACE inhibitor ARB blocker, their blood supply to the nephrons or the kidneys can be reduced. Therefore, at that point, you probably need to reduce the dose. So when there is a deterioration of the renal function to an end-stage renal disease, it is like half the dose and reduce the dose of ACE inhibitor, probably not to stop the dose of ACE
Can I ask you all of you to mute your mics, please? You are disturbing others. Okay, thank you.
Any more questions? Any more questions, Kure?
So is there a specific indication to add insulin as a pharmacological method? They're asking.
Add insulin. Yeah, actually, now according to the new guidelines, you can add insulin at any place. After metformin, you can add insulin at the initial stage. But in our setting, I think the best way of starting insulin is that when the blood sugar control target is not achieved with the oral medications. Even in the world over, that is the same. So you can start with metformin, then you can get on with sulfonylureas are commonly used in our setting, then sitagliptin, then SGLT2 inhibitor or GLP-1 analog. So the ways and means of you are adding the medication. And if the patient is on 3 medications, if the target is unable to achieve, that is the time to start insulin on the patients, because we know that when you add the third medications, your insulin reserves are very, very poor. At that point, there are a few indications. One indication is that with the 3 medications, your blood sugar control is poor. Other thing is that patient may have losing weight. If the patient is losing weight, that means there's insulin deficiency, and that's an indication to start insulin at any point. And I think the cost-effective method of starting insulin is when you're having 3 medications are unable to get the blood sugar control, then unable to get the target, then that is the time to start insulin. And you should understand that the traditional way of starting medications are not there now. You can start metformin if the patient has high cardiovascular risk, patient who has got a high cardiovascular risk, or patient who is already having a cardiovascular problems like myocardial infarction or bypass surgery. Then after metformin, best medication is SGLT2 inhibitor or a GLP-1 analog, not the sulfonylureas. But if the cost is the main concern in our hospital setting, yes, the cheapest is sulfonylurea. So then metformin sulfonylurea is a better option. So I think if the weight is a main problem, if somebody is overweight or gaining weight, then the best medications are metformin, sitagliptin, SGLT2 inhibitor, or a GLP-1 analog. I think that's the way forward that you need to think, because it's a patient-centered way of managing. So what is the patient needs? Is it the weight is a problem? Is it the cost is the problem? If the patient's more cardiovascular problems are there, or whether it's kidney disease, then you're considering different medications. And insulin is whenever you are unable to get the target.
I'm sorry, my connection got temporary cut off, so all the chat questions have been deleted. Students, you can unmute your mics and then ask questions directly from Dr. Bulugahapitiya. I'm sure he'll be able to he'll be pleased to answer them.
Yeah, no issue.
Sir, is gastric bypass used as a method to induce remission of diabetes?
Yes, actually, I think if you look at, now I'm at National Hospital, but earlier I was at Colombo South Teaching Hospital. That's the biggest center for the bariatric surgery. We have done 450 bariatric surgery in Colombo South Teaching Hospital, which is the highest number in Sri Lanka. And now we know that when you do a bariatric surgery, there are certain methods of doing it, like even the gastric, not only the gastric bypass, sleeve gastrectomy. There are various methods. We do sleeve gastrectomy plus gastric mini gastric bypass. Then you do a mini gastric bypass. Then you do a mini gastric bypass with some other mechanisms. So when if you look at our data, like 200 patients, the majority of the patients has completely recovered their diabetes in about. But the important thing is that weight reduction of these patients are all patients who are more than 100 kilos, 150 kilos the weight. But if you look at the weight reduction versus blood sugar reversal of diabetes, there's a clear evidence that the weight reduction is not the influence on diabetes control, because diabetes cure happens within first 2 months or few days time, but weight reduction happens over a year. So without the weight the blood sugar completely getting reversed in about 80% of our cohort. And we know that there is a method of treating patients for diabetes for curing diabetes by bariatric surgery. So we had done about 20 patients who are having normal BMI. Those patients who are on more than 100 units of insulin, and HbA1c is still not even close by. So those 20 patients, they are normal BMI. They are not actually considered for a bariatric surgery by the BMI, but because of the diabetic poor control, we have done about 22 patients, and all patients end up with, majority will end up with nothing, and 1 or 2 patients who only just metformin 1 tablet a day. So diabetes can be completely reversed or to a certain extent cured with bariatric surgery, and it is coming up in the world over, even into the diagnostic guidelines. Although people think that the surgery is expensive, but long-term management and long-term cost for management of complications are more costly than when you consider about the bariatric surgery. So we have about 22 patients who are having normal BMI, have done a bypass surgery, the bariatric surgery, a completely cure is happening. So I think that's one way that we have actually submitted recently was a few articles, all published in international journals, and this is one way that surgeons are fighting and saying diabetes can be cured by surgery, therefore it should be surgical management. And the problem is that how you should give this opportunity for everybody to go through the bariatric. So there are drugs are also coming up that at that huge weight reduction, therefore the diabetes can be cured. And one we have identified the mechanism of the bariatric surgery, what exactly happening after bariatric surgery, because we know where the mice models have been all published, where after bariatric surgery their pancreas is nicely rearranging with beta cells and nicely secreting insulins and become almost normal pancreas. And when you compare the obese mouse, the pancreas is with lots of fat, but after bariatric surgery, pancreas get all these fat is out and beta cells are nicely rearranged. So same thing is happening in the human beings. Therefore, there is a now drug is under development for same as in bariatric surgery to reduce weight and cure diabetes in future.
Thank you, sir.
Thank you.
Any other questions? Students, you can. I'm sure Dr. Bulugahapitiya would like to would please to answer your questions. take this opportunity.
Sir, do we have to use the maximum tolerable use of dose of metformin before adding a second agent?
No, actually, the all these drugs, you need to understand an important point which I didn't want to complicate you, but I think because you asked, I'll tell you. Now, there is a maximum dose of metformin, that is 3 grams, right? That's a maximum dose of metformin, and there's something called maximum effective dose. That is actually that is 2 grams. Yeah, so 2 grams, so 200 milligrams. 2 grams is the maximum effective dose, but the maximum dose is 3 grams. So if you get into any of these medications, the half maximum dose will give 80% of effect. So when you add the next the 50% of the dose, you are probably adding more side effects, and you are getting only a 20% of effect. Therefore, when you go for the half maximum dose, like even in metformin, 1,500 to 2,000 milligrams, when you go, you know that the 80% effect is gone. So therefore, I think you should not try to go beyond that. Then the adding second one is very, very effective. So the point is here, the 50% of the dose will give 80% of the effect. So think about that, then you can add any of these medications properly.
Thank you, sir.
Any other questions?
Yeah, I think we will then call it a day, Dr. Uditha.
Yeah.
So thank you very much for taking your time off from your busy schedule and helping the students. I'm sure you have quite a big attachment to the faculty as well. So you can see students are also benefited with your expertise and your knowledge. So another big thank you to you from PeMSAA, and we might meet up again at another session in some other time. So thank you very much, everybody, students as well. So good night. Thank you.
Right.